Hi, everybody. My name is Natalie Yeadon, and I'm one of the co-founders and CEO of Impetus Digital. At Impetus Digital, we have built some of the best-in-class asynchronous and synchronous virtual communication and collaboration tools for life science companies. We've helped companies over the last 12 years globally with everything from virtual advisory boards, investigator meetings, medical education events, and even recently, we've launched a platform called Insight Events, where we help companies with sales training, corporate events, and everything in between. But more importantly, we really believe at Impetus that everything starts with a conversation. And from these big, hairy, audacious, provocative conversations that we have with some of the bleeding edge thinkers, digital entrepreneurs, and the like, that we can all work collectively to positively disrupt healthcare. And so I'm really pleased that we have one of these provocateurs at the table today. I'd love to introduce to you Bogi Eliasen. And he was actually educated in political science and international law from the University of Aarhus, Denmark. He was previously employed by the Fargen Business Affairs and Ministry of Foreign Affairs, and he worked as a consultant over the last 20 years for all kinds of people, politicians. He worked for the public sector and also for multiple private companies. So Bogi is actually a director of health at the Copenhagen Institute for Future Studies in Denmark. And in his current role, he dives into all kinds of topics, which we're going to get into today, super exciting things, everything from the future of genomics, data, digital functions, and also their integration within the healthcare space. So this is actually based on their holistic vision of wanting to shape personal healthcare paradigms. And this is part of a really ambitious set of projects and a variety of networks that they've established from around the world. So Bogi initiated the first population genome project, which they called Fargen. And this was used to sequence the genomes of the entire population of the Faroe Islands. So we're going to want to dig into that a little. He also received the HIMSS Future 50 Global Award for his work in 2019. And he's also the chair of the Danish UNESCO Bioethical Committee. Welcome, Bogi. It is so wonderful to have you on the show today.
Thank you very much, and thank you very much for the invitation, and also for running these sessions. I think it's very interesting, and one of the things that we need to do in order to bridge the different knowledge that is out there.
I love it. When you go through your resume, it's almost dizzying. The number of things, not only of where you come from, Bogi, but also the things that you're currently involved with. Maybe what you can do is just start off this conversation for the audience, a little bit of what your trajectory has been and how you actually landed in these myriad of positions, roles, networks that you currently sit with.
Yes, so I'm from the Faroe Islands, small islands in the middle of North Atlantic, somewhere in between the west coast of Norway, the southeast coast of Iceland, and northeast of Scotland, in the middle there. Of course, in my childhood and youth, living there, this was very remote. So before internet, this was very remote. We didn't really have television before I was like 10 or 12 years old on a regular basis. And the life was very much in what can I say, more family based, but you also took a lot of part in fishing and herding sheep slaughtering, and you were learned in that way. And the reason I mention this is that what I have learned through my work in the genomic side is that there is a distinction between learning theoretical biology and actually having observed it since your childhood, which is one of the collisions I think we have in trying to understand biology and how we work with it. For instance, in COVID now. So then I went as an exchange student when I was 17 to Brazil in 1990, as it was just the year after the formal abolishment of the military dictatorship. So the country was very positive, but I had never seen this kind of distinction between poor and rich. I also came there without knowing a word in Portuguese, lived with the local family, had to learn the language, went to school. So just that is a learning in itself, because especially the first 3 months, it was so hard just to say something that you actually had to think before you said something. So that was a good learning from that side. But I also spent some time working with street orphans. That's what drives me partly is the consequence I already saw there of decades of dictatorships, what it does to a population, to people, to free thinking. And then these were boys with no prospect of life, average lifespan of 18 years, living from day to day, just trying to get food. So, and that has been very decisive for me on the focus, what we call 1090. So how can we get top-notch technology, not just to focus on the richest 10% of the world, but actually serve the other 90 as well. And from there, I then went to university in Denmark, as you said, where I still live, but I've been back and forth in the Faroes. My wife is from Peru, so I've kept my close connections to Latin America and do a lot of work there now again. I started working a lot more with the political side, as you said, is political science. By coincidence, when the genomic end of the Human Genome Project was really beginning to come to the end, there became a big interest of finding populations to work with. And Iceland was quite fast in working and wanted to have the Faroes in as well. And then I was asked to see if I could try to look at what could you do from a Faroes perspective. And the approach we took was very much to see how can we apply this, not just the research on knowledge, but how can we apply this to benefit individuals and persons. And that's still a project in its making. So I would just say that everybody is not sequenced, but it was the plan, and it's still the ambition. Then I also realized in this work that the genomic was becoming too specialized. So we need the digital infrastructures. We need to have the environmental impact on it. And these 6-7 years ago, when I started to work with the institute, there was not very much cross-disciplinary thinking. So I was looking for a place where there was a methodology to work with and still could focus very much on the future at the same time. So I started at the institute with this, and then began to lead the health part of it and try to see where could we work and where could we be the bridge builder. So I actually don't call myself a futurist. I call myself a knowledge broker. That's what I do. How to get the different knowledges to work together, because the biggest challenge we have is that we focus a lot on hyper specializations in order to become better, but we need to work with that in a holistic manner. And these are two very, very different things. And it's very seldom that you have people that can do both on that. So that's a role that we take in it. So, and in the Institute, we then began also to not just work where we could see, where we were asked to help people, but also to go in and look at openings and gaps where we actually went out and convinced people that we should work on a certain thing. For instance, the Nordic Health 2030 program, where we went to several of the major stakeholders, both public and private, and asked them to work together on a combined direction to work with both digital health, data in general, digital functions, and genomics going forward.
Fantastic. There's just such a mouthful there. And there's tons of things that I want to double click on and explore with you. But I do have to say that your beginnings, where you'd never seen, quote unquote, disadvantaged people economically, almost has a bit of a Buddhist story to it. And that's kind of the beginnings of the Buddha's beginning as well. So I just couldn't help but say that. I thought that was kind of interesting. And, I really love this idea about the bridging. And I just kind of want to explore, before moving on to some of these other things that you're working on, is the Fargen Project, and specifically the Faro Genome Project. You were mentioning that this was this nationwide plan to do genome sequencing and implementation. But what was the primary objective? Because you said something which was really interesting, that, you know, this slant towards understanding the impact of biology versus observation, or, you know, we always hear about the nurture versus, you know, the
Yeah,
genetics of things. So what was the original reason or rationale for starting this project?
yeah. There were several parts of it. So one part is that so the Faroe Islands is just 50,000 people, so it's very small. So it's extremely hard to keep a well functioning health system with all expertise just in the island. So you need to bridge with others, to collaborate on having the right treatments. It can also be hard. So it can also be hard to keep the competences there. And because these are small islands in the middle of or have been very isolated, you also have some specific genetic diseases in that part. So that was also the attention. And when you have these diseases specifically in this society, nobody else is going to solve it for you. You need to do that yourself. But being that small, in order to take on bigger tasks, you would need to work with others. So that was one part of it. Then what we thought we could bring further on with this is experience in working with it, but also to have it in a micro society where you could see, okay, when you learn this on the biology side, how do we apply this in the health system or as knowledge to the inhabitants, and how do you bridge that then with the rest? So if we now jump to the Nordic process that we did in 2019, one of the outcomes was what we now call the humanome model. So you have the biology, you have the micro and the micro environmental impacts, you have your behavior, and we have all the social determinants of health. And in the Nordic countries, a lot of data which is linked to you. So here it doesn't become a question about can you work with this data because the technology is there. Is how do you do it so it benefits the person and the society, which we don't have in place. That requires courage. It requires new paradigms. It requires a lot of new thinking on what is ethics and what is fair and what is unfair. And it also requires that we begin to say person first, jurisdiction next, and not the other way around, as all health systems are working today.
It's a fascinating experiment. When you've got kind of an island like that with a limited number of people, it suddenly opens the doors for all kinds of possibilities. Like you were saying, for genetic disease identification and management. But really, it sort of speaks to what's going on today with COVID-19. Are any of these affiliates, partners, wanting to work with you on COVID-19, the splintering, if you will, or the creeping of new transmissible versions of the virus, and how does this work, and how does spread happen and transmission? So what is going on for today's times?
Yes. So I would first say that when COVID came, we did almost not work online. We almost only facilitated live workshops and meetings. So what we needed to do fastly was to take a decision on in the beginning of COVID. Do we just lock down or not? And the most important reasoning on all of the projects was saying, does COVID change our focus on what we really work with, on anything? And it doesn't. It's the same challenges that we have flagged that we then see in a different way. I mean, we were aware of that something like this could happen, but it wasn't very high up on our radar to work with. No. But what COVID shows us is that we need to work with a personalized health idea together with a public health idea at the same time. These are not opposed to each other. They need to be bridged. What we did fight a lot with before COVID was to get decision makers and non-core digital people to understand that remote care, direct access to information without having to go into a hospital physically, and all of this needed to happen. So sometimes I normally say I feel a bit like Don Quixote, because I've been banging this argument on the door everywhere for 10 years, and then a stupid small biological feature comes in and gets everybody to understand it in a day. But anyway, so that part is there. COVID is tragic. It has caused a lot of negative things, but it's also an opportunity to say, okay, are we doing the things the right way? And I think most people are agreeing on no. Then the second question there is then, is it an opportunity? Do we have the courage to see this? Then let's make the changes. And I think we have a lot of actors doing that. But what we have done many mistakes as well. So we have poured a lot of new things on the market which are substandards. And because you have a crisis, do you need to go substandards on things that we have used three or 5 decades to develop? Probably not. The way we have done isolation, especially in the Western world, has been a bit without thinking and a bit without looking 500 years back in history. What did we normally do on that part? So we isolated the weakest, which might be good in a linear industrial thinking, but the welfare societies are made to protect and help the weakest, not just to put them in a corner and let's see what happens when COVID is not there. So that's a moral failure and an ethical failure that we also need to learn from. And on your question on do a lot of these projects want to work with COVID? Yes, it's taken very much into account. How do we deal with this and how do we work with this? But when we are active in, for instance, the poorer countries in Asia and in many of the countries in Latin America, the way we approach COVID with vaccines and isolation in the Western world is not doable in those countries. You simply can't do it. For instance, in Peru, you have 80% of the workforce that's informal workers. They have a day-by-day salary. Are you going to ask them to be 2 weeks in isolation? It's COVID or die of hunger. Are you gonna distribute vaccine as easily as we do here with the lack of infrastructure that you have there? No, you can't. So there are a lot of these 1090 challenges that come in that we are also trying to deal with and learn from in this. How can we leapfrog the systems with this push that COVID actually is providing on it?
So and just the last question on the Fargen project, specifically because it is, in a population that's 50,000 people. It's a small cohort. It's an experimental arm, if you will. What sorts of parameters or variations can be tinkered with, in which larger countries or even potentially more disadvantaged countries, like you were mentioning, Peru and others, poor Asian or Latin American countries, can learn from what you're doing? What can be tinkered with? What are some of the immediate lessons learned, and how can the Faro Genome Project be leveraged for immediate learning?
Yeah, so I think there have been other good features in the Faroes in concern of COVID. So one thing was that the ability to work biologically with tracing diseases in the very big salmon breeding industry and converge that into COVID testing in a couple of days and actually test very effectively is a great example of that. When you have a small society where people are used to be in the hand of nature, so to say, you solve issues in a very untraditional way. You could also have done in the Faroes what you have done in New Zealand to close down, so in isolations, which was chosen not to do for several reasons. But what you are doing now, and we are beginning to see some of those results, is that there were a lot of interest both from the public and the private research money in the Faroes to look at different aspects of what happens. I mean, what are the consequences? Are there different? Are there specific groups that get it? So these results will probably come in a couple of months. But what you have in the Faroes in other projects also is a very, very a very, very long tradition of cohort studies where you keep a high number of the people in the cohort because there is a trust in between it. So probably there we will be able to learn a lot on COVID if we choose to take a focus on it, because I mean the whole world is asking now what happens, how long does the vaccine keep you safe, and what are the consequences for people, and are there other things we should take into consideration, and these are things that definitely are possible to do there.
The work that's being going on with the institute that you currently work with, Copenhagen Institute for Future Studies, doing some really interesting things around what you're calling megatrends and this concept of futurism. How do those in general help the studies, the projections, the predictions, and the ideas that can be generated for people as we sort of inch along into the new normal? What are some of these concepts around megatrends and futurism?
Yes, so let me first say it's the institute is called Copenhagen Institute for Future Studies in plural, because we don't work with one future. We don't have crystal balls that tell us one future. So what we work with is that we have a base of megatrends that we use as main drivers, and from that you look at the combination of different things. So we know from our work for more than 5 decades that the real changes do not happen in a linear progression of a trend. It's the collision of trends. And there we seldom can say exactly what will happen, but we can work with that something will happen, and then we can work with scenarios. What are the possible scenarios in that? But it also gives a tool when you work more on a more granular level with companies or institutions. It gives you a tool to work out, okay, what is your area of influence? Where can you have impact on this? So that's one part. The other part is also to be very clear on where are drivers, so to say, where can you surf? Where will others solve issues so you can focus on using your core strength where there is a gap to work with? And this comes back to, and this is the way we work with this on the health team and in general at the institute, that most challenges that we have are what we call wicked challenges or wicked problems. It's very complex. You need several parties to solve it, and maybe it's just a journey. Maybe there is no end date, but you need to continue to work with it, because every time you solve something, you open new doors of new challenges. So the identification of where is it actually you can maneuver, where is your maneuvering room, and the identification of where are the streams in this. So that's one side. And if we, for instance, build 4 likely scenarios that we often do, it will also give you a radar to look at when you see the things that you have mapped. Let's see, it's 30 parameters that you map. If they go in a certain direction, which is in your scenario A, you know that, okay, now the world is moving that way. So if I want to go that way, I encourage it. If I wanted to steer in a different way, I need to work to get it in a different way. So it gives you an agile strategy way of working as well.
I absolutely love it. And I love that you brought up the systems thinking, kind of like innovation systems thinking. It's a much more holistic, broad scale. And we're right now posed as a global ecosystem to start indulging in that, where we're being exposed to multiple variables, multiple versions of the truth, in everybody's own interpretation of it. We see a lot of this written on, by people like Roger Martin. He's a famous Canadian who wrote a book on integrative thinking. And so I absolutely love that you brought that up. And so that actually brings us to some of the work that you specifically have done. I think you did this in conjunction with Roche, which is a pharmaceutical company. You're calling it FutureProofing Healthcare.
Yes.
And also integrated with that is this launch of the European Personalized Healthcare Index. I want to get into the individual roadblocks in just a minute, but can you maybe introduce why this came up in the first place and what the objectives and the focus is of this particular initiative?
Yes. So it actually started as a European work with sustainable health. So the first index was a sustainable health index, and I think there was one on breast cancer as well, to look at the European countries, and it was less a focus on comparing and competing, saying who's best, and more a focus on learning best practices and maybe seeing what not to do. But the core aspect here is to have a dialogue tool, because we need to work cross border to solve many of these issues. And then we also worked with a MS index, and then the idea went on saying, okay, if we really want to work with the new paradigm, then we need to look at something that helps in understanding what do we need for personalized health. And that becomes much more difficult in a way that it's as much about readiness as it is about being able to see what's in place, because this is something we are only at the beginning of this voyage now. So what we did was trying to go out and say, okay, if we constructed the perfect personalized health index, what would be in it? Then we built that up, of course, with huge inspiration from what we did before, what WHO does in some, OECD does in some, and the other known indices, and that we also use data from other indices. And then we looked at, okay, what do we not see, but where we know we need knowledge, and try to both to produce some of that knowledge, and also use some parameters that could substitute for that. And the idea here is also to have a knowledge base to go out and discuss, okay, where are we? Where is it we want to go? And how does the world look? Because what we have done, and that I only realized when we began working with the index, is that we have preached data-driven health and learning health systems without data, which is a bit absurd, but that's what we have done. And so this is a stark way of saying it's fine, we can work with data. It's good that we have learning health systems. It's very good that we learn from each other, and we need to work cross-border, but we actually also need to assemble the data and work with it. So that's the one thing. The other thing is that most of the usable data and very good data that's out there is very hard to access if you don't work with those kind of data on a daily basis. So what we also wanted to do with this is to have an interface where you can go in and use 10 minutes, half an hour, 1 hour, and actually get an understanding on where are different things. So what is it that's important or less important? Where are countries strong and not strong? So you don't have to sit for a week and try to dig and merge some indices. So the very important part here is, if you don't like alternative truths, as you said it, or fake news, or that you get misunderstandings on how science works and how health is, then we actually need to serve the data so people can have access to it. So it's a lot about literacy in that format as well, for politicians, for decision makers, for companies, but also to bring a platform on how can we work together. So how can we align on things so we actually get more out of it.
Absolutely, beautifully said. And there's some really neat components, and I love the way this this index has been pieced together, almost like Lego blocks, sort of like the amino acids or the core components, and you've kind of built these so that people can use this as a roadmap. So the first Lego block to this personalized healthcare index is really around planning and enablers. And you have a series of things or components within that building block, everything from what is the strategy and investment? How are you increasing patient awareness, connectivity, and like you said, literacy? How is the workforce being implemented, incorporated into this? How are people collaborating? And I think the thing that I'm especially interested in you expanding on is around system incentives. Because at the end of the day, systems thinking is really based on energy goes where the money flows. And so people need those incentivizations to, unfortunately or fortunately, depends on how you look at it, they need those to be able to encourage certain kinds of behavior. So can you speak around that first Lego block of planning and enabling?
Yes. So yeah, let me just first make the connection. So what we have tried to do is that we have some vital signs in the index, and then in these blocks that you are mentioning, it says if so that is connected. So if you see that you want to strengthen, or you have a weakness, or you want to enhance something that you see in the index, you can go into these blocks and see, okay, if those are the parameters, this is the area, and then there is some inspiration for it. So for the system thinking and dynamics, yes, it's quite clear that what we have done the last 5 or 10 decades, depending on where you are in the world, is a huge leap forward. But it has also been what is often now labeled as a one-size-fits-all approach to health, and it has its right. It has been beneficial, but we are on knowledge. We know today, and we have the insights to understand that we can do better than giving the same to everybody. So that's where personalized health comes in. Currently, there is not much incentive to work in that way. So you need to take a risk in order to do it, both in the hospital system as a health service provider, also as a company when you work with that. The other side is that when we go back and look at the last 200-300 years, the lifespan in the richer part of the countries has gone from just below 30 years on average to almost reaching 90, right? But the one that became oldest 300 years ago, they reach the same age as they do today. So we have lifted the average lifespan, but not the peak lifespan. And that's often misunderstood when we work with this. And when you then look into all this research about especially old people, centenarians, it actually shows that a majority of them are old because they never were ill, not because they were well treated in the hospital system, right? So there are other things we would need to begin to look at outside. And when we look at what really accelerated the lifespan in majority part of the world, it's clearly that hospitals helped a lot with accidents and communicable diseases. But so did clean water, schooling, better working conditions, better roads, and yeah, education in general. So that's what we also need to understand in health going forward, that it needs to be a bridge between the clinical side and the non-clinical side, and how do you make that work together? And the incentive, and that leads to prevention, and the incentives for prevention just isn't there. And that will probably require new payers today, and I will say this quite hardly and brutal. We have some free riders in the system. The biggest ones are the insurance companies and the pension funds. They need to come into this game and be a part of the risk takers, because they have the benefit of the prevention as well. Prevention needs that we begin to think in lifespans and not in 1 year budgets or 4 or 5 years political cycles, but from cradle to grave, or womb to tomb, as we begin to say now, because we can already work before you're born. And we need to understand where is there potential value in society that can be capitalized in different ways when you provide improved quality of life and well-being, because that needs to be the goal. It should not be the goal to build more hospitals or more technology. It's how do we provide increased quality of life and well-being during the lifespan. Will we still need treatments? Of course. We will still be ill, but the challenge for societies, what makes health system non-sustainable, is that for every year we gain, we take with us half a year with disease. And if our work activity during the lifespan is the same, and we live 30 years longer and half of them are with disease, it's obvious that's not good. Economically, it doesn't work, but for well-being on personal reasons and dignity is not good either. So that's where we need to push that forward. And how we do that, that's where we need to ask questions.
So fascinating. And again, so many components to this, innovation systems thinking here. You've brought up a lot of good points, but I think one that we can really linger on and maybe explore further is really around legislation, policy, guidance on a myriad of different topics, including things like gene editing, machine learning, talking about patient data privacy.
Yes.
Big topics to explore, but do you want to attempt to try to break some of that down for us?
Yes, I would love to. So you asked about the interest for post-COVID before. The requirement for working with us post-COVID is to have the courage to bounce forward and not go back. So we might have a lot of rhetoric on calling for new normal, but all the action we see is going back to pre-COVID. So the courage to work with a post-COVID system is really missing. I will come back to the legal parts, but I will just say that our challenge is not technology. It's the courage to take decision, and it's the ability to carry them out, especially from a public side. And then when it comes to the legal frames, what we are trying to push for, it might be very naive, but we still do it, is that what's happening now is that we only take the legal challenges or the legal discussions once we have the challenge. We have known that gene editing would come for at least 10 years, that CRISPR has been in the making and now is very usable. The discussion has been there for 30 years, right? We have known about working with genomes since the Human Genome Project was realized that this was really on the table now, and we need to figure out what to do. So what does this do? What happens is that we are trying to find solutions in the current paradigm, which does not work. And when you actually, and this is also system thinking, when you realize that we can't solve the issues in the current paradigm, you need to ask questions before you come with the solutions. And that's a very, very hard thing to do. So I'm also co-chairing the income cohort of the SCIANA network, which are health leaders in Germany, UK, and Switzerland, where we are taking some of these issues up. And in Movimento, the big project we do in Latin America, is we're also trying to see how do you deal with this in emerging economies, because you still need healthcare, and why shouldn't you be a part of the new biology that's coming in and using the data? So when we take the question about privacy, what is this about? This is about traceability. It's about accountability in it. And it's about transparency. So why is it that when we the last, 5-10 years have shared everything without thinking on the telephone, that it's so dangerous when it's something that can help your health, right? 90% is the same data that we need. So we also need to think, why does it become very dangerous when it's something? It's the same with the genomic discussion. Yes, there is a possibility for abuse, but if I want to have your DNA, there are a myriad of ways I can have somebody invite you a cup of coffee or something. The access to the data is very easy in other ways. So what is it we are protecting and why? And my point here is that if we want to go to the next level, we need to share data. And it's not enough that we share anonymized data, because when you want treatment or you want health advice, you want it personalized. And I'm pretty sure you don't want to be an anonymized patient when you come into the emergency. You would prefer that I know who you are. So the question is probably not how do we put privacy on top of the challenges we have now, but how do we rethink that? So it's not so difficult to deal with. To me, there are three factors in it which have been totally forgotten in the new digital age on personalized health. So what we did with human rights was a protection from the state, a protection from commercial entities, and protections on your life from bandits, villains, whatever, on that way. We don't have that protection in the digital age. So unless I can promise you, if you want to do good, you want to share the data, both for your own sake, but also to develop the knowledge so others can benefit from it, we need to get a promise that this cannot come back and haunt you in the future, in insurance, in work relations, in whatever. That's the biggest challenge we have. I don't have the answer, but we need to ask the question. So here are some of the things, and we have seen it now in COVID. It would be very logical that the whole world just came together, said, okay, we have a global app, let's get the traceability in there. Let's get a biopass in there. Let's do it. The technology is there, right? But here comes the power of data. And the current regime has it that business is owning or controlling volume of data. The next paradigm would need to move the business model to the functions of data and the digital infrastructures and have the data being free flowing. If we want to achieve what we're saying we want to achieve. I'm not saying that's the right thing to do. I'm just saying, if we want this personalized health, if we want equality and equity in health, this is what we need to do. And does this break totally with our understanding on how we protect data today? Yes, it does. Does it provoke us on saying that we need to share data cross-border? Yes, it does. So we could just take an example on breast cancer, which is fairly advanced when it comes to biomarkers and the genomic information, if it's BRCA1 or BRCA2. So you would actually like to know who around the world has treated how on this specific variation that you see on this cancer. And do we have the technology to have that in a real-time updated database? Yes. Do we have the system that can approve that that works? No, because we don't want that. We want something that's fixed, right? So these are challenges that we will run into and we need to deal with. And I'm pretty sure that if we can't do it from the public health systems, it will come from other places because the benefit is big.
Just there's so much there, and I'm going to be asking some fairly deep existential questions here, but data is the new gold, and we realize in that this very social, economic, upheaving economy that we're in, people are grabbing at things that are of value. So, and also things are worth whatever seems to be scarce. And so if data, we are actually increasing this value of data, somehow it has this immense value and that somehow we need to secure it. I think we're also in a really interesting political situation where there is distrust, there's an unevenness and a suspecting of truth in everybody's version of it. So people are really trying to hold on to whatever they believe is saleable, is physical, is something that they can actually put their hands around. And so people just want to engulf that and not give it away. I think that we've seen this in the lack of altruism, if you will, of people wearing masks or people getting the vaccine because it's all about them. It's not caring about the bigger global situation. So part of that also speaks to the narrative around sharing or not sharing my data. I want to hold on to what's mine and not really care about what the rest of the world or the ecosystem is. Yeah. So I'm just wondering if you can kind of speak to the individual in this, in the milieu of distrust, economic upheaval, and social dynamic unrest that's happening today.
Yes. So one of my experience of being in many places around the world the last decades in workshops and giving talks was that I've always seen myself as a hillbilly from a small country. But I've never met bigger hillbillies than urban people from big cities. And that comes into that biology. In biology, you are a product of time. just like our system of law is also made when you have ideas. It's the idea of time, right? So your genome, you might be very special, but you're almost the same genetically as most people you know, right? Your data alone will not benefit you or anybody else because you can't compare it, you can't learn. So that is where this urban extreme anarchistic liberalism has made a how can I say an understanding of that you alone are the God in the world and of your life. But I think COVID has shown us that that's not how the world works. So I think that is one of the things that we also need to deal with. And I think we will if we so there are some extremes, and just to make it black and white, there's a reason why we're not living alone in each in one cave. There's a reason we want to go to societies and work together. And of course, I'm not saying that all data about you should put on your social media profile. That's absolutely not what I'm saying. But I'm just saying that knowledge in your data you only have because others have shared. It's because we work aggregated and then funnel it back on an individual level. And this is the biggest challenge we have going forward with bridging the personal health with the public health, is the understanding of, on both sides, that if the public, the aggregated, wants really quality data, it needs to come directly from some kind of an individual, and it needs to go back, be enriched, and come back again so you can work on a lifespan with it. And I have every respect for a person who says, I don't want to be a part of that. I think we can live fine without it, which I think is very good. But we should also think that we can do a lot of things with changing of behavior, with knowledge, and with early intervention or prevention if we have these data sources accessible and usable in a systematic way. So in order to speak to people, I do understand the distrust, but I do think that here it comes back to my three major points of traceability, transparency, and accountability. We are beginning to get digital systems with ledgers and blockchains where you actually can secure, if not secure the data, you can see who at least is trying to do something with the data. And that's probably the furthest we can get with this today. And just having in mind, even if you don't have a phone, a computer, something that's online, CCTV cameras will still make you digital in the world. So, I mean, I think that time is over when you can say I'm analog.
It's a really interesting question, and we're seeing a lot of the push-pull that's going on as we're moving into a new era with a lot of people clinging to the past in fear of the future. We're seeing this in geopolitics, obviously all the things that we're seeing in the United States currently, and the fear of what is next and what is that we're not familiar with. And so the question comes down to is the general politics of it, the understanding about what it means to be a citizen or a digital citizen, if you will, because that's, everybody's going to have a digital avatar. And where does freedom start and where do they stop? Where do governments start and where do they stop? And all of that is going to have impact on data interoperability, access. One could certainly over time compare outcomes from even this COVID-19 pandemic, who was able to bolster the citizens really quickly, eradicate it from, bring businesses back to economic, feasibility, and then, base that on certain parameters like, ideology, politics, et cetera. So where do you see this faring, in terms of predictions, as we talk about megatrends and futurism? Where does this kind of play out, and who do you think are going to be the winners and why?
Yes. So there are a couple of points here. So, and you mentioned something in the beginning which we haven't touched. So we will not go anywhere without artificial intelligence, machine learning, and those parts. That will be an integrated part of it because the volume of data we need to work with is just too big. Just take the genome, is 3.2 billion base pairs. You cannot work with that on a manual level even if you wanted to. So that's one part. So I like to distinguish this into the new biology. How do we work with that? Digital infrastructures and functions, and data. So three components in that part. So when it comes to the new biology, we are on the very, very beginning of understanding. Almost 20 years ago, when we had the human genome, the first draft of human genome, there was a huge splash, and we thought we had learned most. Then we have learned that most things are complex and multi-genetic, and we can't really do it that fast. And now we're also getting into a whole bunch of different omics on different biological levels, and also a focus on the single cell, in really to understand how do we work with these things. So that's one part. One of the things that we really want to work with also is to be really critical on what is hype and what is not. How long is it to market with some things and what isn't? So I work a lot with ethics, but my thought on this is that we are going to sequence everything, every living organism, or a sample of every living organism is going to be sequenced. Every history fact in books is going to be checked with some kind of new biology. Food tracing is going to be sequenced. We see, the only reason we know so much about COVID is because of the sequencing technology. So this is here. This is the breakthrough of the sequencing technology. So the generations in school now, for them, this will be as normal as computer is for somebody at our age in this part. So that will come with time. So we will get more comfortable with that. And I think system thinking has to come back to those things. Where huge leapfrog will happen, I think, and I've said so already for 5 years, I think that the next steps will not come in the richest country. They will come where there is a huge need for basic things which makes a huge difference in how much health service you can provide. So that can be apps that just helps you with some basic things where you don't have access to doctors. That can be focusing on biomarkers, pharmacogenomics, where you don't have money to biobanks and full genome sequencing. Partly because the need is bigger, partly because they're not constrained by the hospital systems we are in the Western world. And partly also because there are huge populations which are not constrained into smaller countries or smaller states or provinces in countries. So the scalability is much bigger. And it's 90% of the world. So I think there will also come a business drive on that. Our obligation as society is to ensure that this happens in a feasible manner that benefits those populations, both on short and a long term. And we see, we see a lot of push forward in China, South Korea, partly in Japan. We see some very aggressive health plans in the Middle East, both in Qatar, Saudi Arabia, and the Emirates, where you, for instance, are focusing on getting people more active as one of the most important things. So we are already now beginning to see that we move away from just thinking about the clinical space and how do you fund and incentivize the clinical space, to how can we work outside of the clinical space and keep people healthy. And this comes back to WHO's hard push on leaving no one behind, and also on keeping the healthy in different ways, which we also need to focus on. What I think will be a huge change in the way we have seen modern health the last 5 decades is that we will put more responsibility back to the individual, to those individuals who can, to take responsibility to keep themselves healthy. That will liberate more resources for those in our societies. Is around 20% who need more help to come back, to have a better quality of life and to be better. And this is just because we should use more energy of those who need more, and not as now that we use a lot on people who might not need it that much. So that's also a new way of thinking justice and equality and equity in it.
Honestly, Boya, I could speak to you for hours about this. I mean, everything from collective consciousness, Elon Musk's Neuralink, to the push-pull that's going on with the contraction and regionalization thinking versus the globalization, and on it goes. So maybe this actually will set the stage for a future discussion, but I think I'll end it on that, on a very provocative, thought-provoking idea. I just want to let everybody who might be listening to this afterwards, if anybody's interested in contacting Boya, either for a partnership or to understand further or to do something, an interesting project, we will be leaving his contact details and the Institute's website so that you can connect with him afterwards. If you enjoyed this conversation, I'd encourage you to also check out impetusdigital.com. Using our asynchronous and synchronous virtual collaboration tools, you can have conversations like this with your stakeholders, physicians, payers, allied healthcare providers, patients, as you're thinking beyond the pill, doing something that's different, planning, doing megatrends, futurism, dissecting some of these concepts so that you can reach consensus and can create position papers and ongoing dialogues. If you like this, please subscribe, like this video so other people can find this. We'd appreciate that. Thank you, everybody, for your time today. Thank you, Boya. It was actually a wonderful conversation, and wishing everybody a wonderful day ahead.
Thank you very much. This was a pleasure.